Okay, all right. Hello and welcome everyone to our webinar titled Fighting the Attacks on Science and Public Health. Under the current administration, we're facing a near constant onslaught of program cuts, data restriction, and defunding. How do we navigate a new landscape where public safety measures are being dismantled at the same time as the data that we use to measure the lived effects of this dismantling is also being restricted, augmented, and taken away? With the new phenomena of immigration enforcement officers being allowed in hospital settings, how do we create an environment where patients are still able to seek care for both rights to dignity and also in an acknowledgement that all members of the population must have access to healthcare and prevention mechanisms in order for there to be any real progress towards the eradication of disease? Today, we will hear from public health experts and healthcare providers on their view of the current landscape. And at the end of the call, we'll introduce the Protect Our Patients campaign with 4 simple steps that healthcare workers can take to make healthcare safe again. And then after that, we should also have some time for Q&A. Additionally, this meeting will be recorded for reference later and to be able to share with colleagues and friends. All right, so first we're going to hear from Dr. Noha Abalada of Roots Community Health.
Good morning, everyone. It's great to be here with you all. I'm Dr. Noha Abalada, founding CEO of Roots Community Health in California. We were established in 2008 as a 2-person volunteer operation, setting out to really understand and address troubling health disparities in our community, which we call Deep East Oakland. So from our very inception, we have been on a mission to uplift those who've been impacted by systemic inequities and poverty. And we do that not only by providing healthcare and behavioral health and navigation and workforce enterprises and a whole host of wraparound services, but also importantly by advocating for systems to change. Because we know that our systems, including the healthcare system, have created and maintained disparities in this country from the start. So we purposely put ourselves where health and other disparities are the highest. We hire and train folks from the community, and we are uniquely responsive to our community's needs. And so since that 2-person volunteer operation, we've grown to a full-time staff of about 250 people who really reflect the community that we serve. So in many ways, when the pandemic hit in 2020, we were well positioned to quickly meet many of our community's needs because we had already established that critical foundation of trust. And we became a sought after resource for not only testing and later vaccination, but also for clear and honest communication about what we did and didn't know and how we were approaching the crisis together. And so from the onset of the pandemic, our responsibility was clear: to protect our patients, protect our community members, which includes our staff and their families and their households, in addition to the people that we serve. And so, in fact, from the beginning, the motto at Roots is healing our community from within. And we absolutely mean that. We cannot be of service if we ourselves are sick, and we could definitely never risk getting our own patients and community members sick. So in addition to our masking requirements, we invested quite a lot into free testing, free masks for our community and our staff alike. And we managed to just normalize testing and masking and community care. And that has stayed consistent throughout all the changing and often conflicting guidance that we're receiving. And as an organization, we've revisited our masking policy several times, which still includes masking throughout the whole organization. And what we have found is that our staff feel protected by our policies, and they feel proud that we're setting an example within the community. So I feel really fortunate that we have not only the buy-in of our team, but also of our patients and our community. And so even though everyone might not always love continued masking, they respect the policy and they respect the clarity and understand that it is for the greater good. Our responsibility is to each other, and we never take that responsibility lightly. So today, masking is completely normalized within our clinics. It comes with the comfort that we will not infect our own patients or each other. And although it's true that there is an expense involved with continuing to provide free masking and testing, I'm also proud to share that we have never had workplace COVID transmission We don't have teams that go out sick, and the only transmission between coworkers that we are aware of happened with colleagues who carpool together. So even though this is all a very serious matter, my staff know that I often joke with them, COVID does not get off at 5 o'clock. And so along those lines, in 2022, we established safer gathering policies. And so that includes when we go off site, we have pre-event testing. When we do tours together, we have pre-event testing so that we can gather more safely. And again, this is an investment of time and resources and training for our safety leads, but this allows us to be a little bit more relaxed with our guidance after everyone tests negative. And we've also done quite a lot of work to assess and improve and monitor our indoor air quality and continue to provide hybrid and remote work options wherever possible. I also wanted to share that because of our leadership and advocacy in this space, we've been very fortunate to enjoy productive partnerships with our county public health departments, where we've been included in discussions and decision-making about county level policies in both Alameda and Santa Clara counties. And while, of course, things did not always go the way that we wanted them to go, I am proud to say that in the counties where we operate, these are among the very few that have healthcare masking requirements for the duration of the flu season. And we wish that that was the case, of course, all year round, but definitely in more places across the country. So in closing, I'll just say that we cannot unknow what we know, which is that especially given the fact of pre-symptomatic COVID transmission, we now see masking in the clinics no differently than universal precautions like wearing gloves, which we know. And when we know better, we have to do better, irrespective of what so-called everyone else is doing, because those same systematic injustices that necessitated establishing Roots Community Health in the first place continue to exist. And so while the sheets are being pulled back as we speak, as the introductory comments talked about, they're really only revealing what was already there. So our job has not changed. Our job to heal our community from within has not changed. And our imperative to be clear and consistent is even more critical now than ever. Thank you.
Thank you so much. Next, we'll hear from Dr. Theodore Pack, who will present the findings of his article, Testing and Masking Policies and Hospital Onset Respiratory Viral Infections.
Hey, thank you for the intro, and a pleasure to be here today. Just want to confirm, is my screen showing up?
Yes, we
Excellent.
can see.
Okay. So yeah, I'm going to talk today about this paper that we recently put together called Association Between Hospital Onset Respiratory and Viral Infections and the Masking and Testing Policies across 10 hospitals in the New England region. I'm an infectious disease fellow at Mass General, but just want to clarify that for this talk, I'm speaking on my own individual accord. I don't represent my employer or set any policies at MGB. Okay, so yeah, the question that we tried to answer here is, as masking and testing policies evolved throughout the pandemic, how did that actually change rates of hospital onset COVID, influenza, and RSV? So just to set the stage a little bit, this is what our hospital looked like in March 2020 when I worked there. Pretty much over half of the hospital had precautions throughout patient rooms like this. Perhaps one of the more visible signs of these changes was at the entrance to the hospital, where when you come in, everybody is asked to put on masks. This has largely faded away as the levels of respiratory viruses have come down. In 2023, we actually saw in a lot of medical journals that leaders in hospital epi were publishing editorials about why some of these measures were no longer necessary and that maybe it's time to stop them. The reasons that they were giving at the time, there's a lot of them, and I won't go through all of them, but the running through line was that some of them felt that the cost was not sustainable. Around this time, you'll remember that federal public health emergency funding was very publicly ending around May of 2023. Our group and some of my colleagues had a different opinion on this, which we also published in journals at the time. And I just want to highlight for the group, there's a lot of arguments to keep these tools in our toolkit. As was just pointed out, a lot of people that transmit COVID and other viruses are asymptomatic or pre-symptomatic when when it happens. It's the most common window for transmission. So without some level of universal precautions, it's likely that a lot of people will not know that they have an infection and that they need to isolate or wear a mask if it's not universal, for instance. I also had a lot of concerns about equitable access to care. Many of my patients were telling me in 2023, I'm not comfortable going to the hospital because people aren't masking anymore. And this was very concerning for me. And I saw it affect patients' care in some instances. Um, Although the dialogue around COVID infections continues to be skewed, in my opinion, toward that there's not as much harm as there used to be. If we look at the hospitalized population, honestly, that's not necessarily the case. We'll see that in hospitals, there's high concentrations of people that are at high risk for bad outcomes with COVID infections, particularly when it happens while they're in the hospital for some other reason or some other serious illness. Um, in our own study that we looked at across hospitals at Mass General Brigham, when we did our best possible apples to apples comparison of patients that are getting Omicron COVID in the hospital, several days into their stay, matched against similar patients, there's a 60% increase in death that's occurring with those hospital onset Omicron cases. So this is not something I think experts should take lightly or that should go ignored when we set policies about preventing infections in the hospital. Um, there's not a whole lot of studies, though, on the efficacy of these interventions, probably because it's been so impractical to do this in the pandemic setting. Many of them have been small, and pretty much all of them have been observational, unfortunately, in healthcare settings. One large one that we did on testing used data across the United Kingdom, and this was when the United Kingdom pulled back on universal testing toward the end of 2022, and you can kind of see in our results here that levels of hospital onset COVID, which they publish online across entire countries like Scotland and England, had risen after that change. A lot of folks, experts, sort of debated the meaning of these results, and it's part of the reason that we decided to do a new study focusing on Massachusetts hospitals where we had a lot more data. We could dig deep into individual cases and see, are these true cases of transmission? Should we be concerned about changes in these numbers around the time of policy changes? This is what the policies look like at Mass General Brigham hospitals. The hospitals phased in universal testing and masking toward the end of 2020, added serial testing. So if you're in the hospital, you just get tested every 5 days, no matter what you were there for. And then May 2023, all of this pretty much ended all at the same time, which led to this period with no precautions. And then around January 2024, the hospitals started masking of staff only in response to higher levels of respiratory viruses, which you'd expect every winter at a minimum. In this study, I'm just describing here some of the statistical methods we used, which adjusted for things like seasonality and, importantly, community onset rates, right? In a study like this, you're always going to have a correlation between levels of COVID, RSV, whatever in the community and what you see in the hospital. So you would only really care primarily about changes in hospital onset rates relative to the number of community infections that you're seeing at that time. This is just some data from Germany demonstrating how every wave of the pandemic had that correlation between community cases and hospital onset cases. So to answer some of these questions about whether the numbers that we see and how they change reflect actual changes in transmission versus artifacts related to what you pick up when you have universal testing or selective testing, we also did a deep dive on about 100 patients to just see, are these truly hospital onset cases that suggest that these folks actually started to have symptoms in the hospital, had a serious COVID infection multiple days into their stay. So to quickly review the results, these are just the top line numbers of how many cases of respiratory viruses we were seeing throughout these different periods. You can see we're looking at hundreds of thousands of admissions here. So I think this is a pretty broad sample. And you'll notice after masking and testing ends in this period, just the raw ratio between hospital onset respiratory viruses and community onset jumps from 7.6% to 16%. This is what this looks like, just visually. If you're just drawing a flat line through each period, before Omicron and after Omicron, there is kind of a shift in this baseline of how many COVID and RSV and flu cases that we see in the hospital are actually starting far into a hospital admission. And then this appears to rise again immediately after masking and testing ends. Um, in response to other experts who said you have to adjust for seasonality, other factors here, which we did take into account in this particular model, there is still a significant increase in hospital onset cases when you allow some more flexibility in how your modeling changes over time. And this comes out to about a 25% increase versus a continuation of the prior trend when masking and testing ended. And then when the hospitals restarted masking, there was a 33% decrease in hospital onset rates. In our deep dive on 100 patients after universal testing ended, we do believe these cases are real cases of hospital onset, likely hospital acquired COVID. And that's because we looked at things like how many times they tested positive, were there new symptoms at the time? And this was, again, to address concerns. Hey, maybe these patients had long-term viral shedding from a prior infection, and you're just picking that up late in the admission. And in general, for these cases, we're finding that's not the case. These are real likely transmissions in the hospital. There are a lot of limitations in this kind of study. It would be wonderful if we had better prospective studies of this kind of phenomenon, but there's a lot of reasons that's not possible. Obviously, it's possible there's still some confounding in this kind of study, but in general, these are my takeaway conclusions. When you end testing and masking across about 10 hospitals, you see rises in hospital onset infections. When you start reinstituting the precautions, you see decreases. This is all suggestive to me that these universal precautions do matter still. They are useful tools in the infection prevention arsenal. Are they practical to do at every single day, time of year, in every single setting? I'm not sure, but certainly in higher risk times of year, these are things we need to highly consider bringing back because we're way off where we used to be for these particular policies. So thank you again for the time, and I'm happy to answer questions on the panel after.
Thank you so much, Dr. Pack. And for all of our participants, if you have any questions, please drop them in our Q&A box instead of the chat, and we will address them in the Q&A section at the end. Our next speaker is Dr. Lara Germanis, clinical instructor of medicine at Harvard Medical School.
Can folks see my slides?
Yes.
Perfect. All right. Well, thank you so much. And thanks to everyone for being here today. So I'm going to take us a little bit more broadly to sort of think about the way that the policy changes that have come kind of as a flood are really impacting the broader fight for, a thing that we should all be inspiring towards, which is protecting life, liberty, and pursuit of happiness for all. So let's just take a look back first at the COVID pandemic, which seriously impacted the life expectancy in this country. And I want to point out a couple of things here in this graph on the right, which is to show that, first of all, the United States started with a much lower life expectancy than other developed countries. We're actually much lower than any other countries. And a lot of research over the course of the past 30 to 50 years has really focused on why is it that the United States, that we have such poor health outcomes when compared with peer nations. These differences were substantially exacerbated amid the COVID pandemic, where we see that life expectancy at birth dropped drastically, but in particularly dropped in different populations of people of color. And so these inequities especially impacted the people in the Black community, American Indian and Alaska Native, and Hispanic or Latin. It's important also to be aware that these things are also drastically impacting a large portion of the US population, in particular also disabled people. More than 1 in 4 people in the United States are disabled, and more than 4 in 10 Americans are non-white. So what should we do about these racial inequities? There's also abundant data and an entire field of public health dedicated to trying to understand why health and healthcare among people of color is worse compared to white people. And I'll give you a hint, it's not because they are biologically inferior. So the ultimate ethical question here is, are we supposed to do something about this? So why are people of color dying young? Well, what we are finding, and actually in my work, I run a social determinants of health screening program in my health system. So social determinants of health impact people's health more than genetics or even access to healthcare. They are the non-medical things which impact health. And if you think about this, it just makes sense. A whole lot of what determines how healthy you will be, how long you will live, has a lot to do with whether you have access to healthcare, but also whether you have access to education, the social and community context where you're living. Do you live in safe and stable housing? Do you have transportation? Is your neighborhood safe? Is your air clean? Do you have access to clean water? Do you have access to nutritious foods? Are you working a job that allows you to take care of your body and exercise? And it also includes, there's also a breadth of research demonstrating that racism itself impacts people's health. It creates kind of chronic stress, which impacts not just people's mental health, but also people's physical health. And so I just want to focus in on the concept of equity, which has come under attack by the Trump administration. And it's really important, instead of saying DEI, to be saying these words and to understand exactly what the Trump administration is trying to eliminate. They're trying to eliminate diversity, equity, and inclusion. So Trump is calling this image on the right discrimination. So if you look at these kids on the left, like this is the sort of equality situation. Everybody has equal interventions to allow them to look over the fence at the soccer game. But here on the right, there's an intervention which makes things more fair. And so you can see that whereas equality, where everybody gets the same thing, it isn't really just. It's not right. Not all the kids have the same access to see the game. And so when you intervene in an appropriate way to make something accessible, which is another hot button word that is currently under attack by the Trump administration, and I'm going to share some information about how this is concretely being done. But when you make things accessible, it becomes fair for all, and everybody has equal access to something. And of course, this is watching a soccer game, but it also applies to things that are even more important, like access to quality education, access to appropriate healthcare, etc. Trump has been weaponizing the legacy of Dr. Martin Luther King to attack equal rights for all. This is a picture of President LBJ right after he signed the landmark Civil Rights Act of 1964, shaking the hand of Dr. Martin Luther King Jr. That was a landmark civil rights and labor law which prohibited discrimination based on race, color, religion, sex, and national origin. And that law right now is the basis upon which the Trump administration he's actually using this law to attack access to healthcare for people of color and people living with disabilities, among others. So, the plan from the Trump administration for health inequities is to ban words that describe and research that fix these problems. And among the words that are suggested to be banned include women, um, uh, privilege, inclusive, inequality, injustice, LGBT, mental health, accessible, and many others. It's pretty shocking. And I just want to be very clear about this. This is not like a kind of fantasy land, like it's only happening in some places. I'm hearing from my colleagues who work in the Veterans Administration, completely illogical and ridiculous versions of this. For example, pharmacy residents being told that they cannot use the word inclusion criteria, which is a technical term for the purposes of doing research. It just says, like, who did you include in the study and who did you exclude from the study? And they're not even allowed to use that on a research poster. So they have to make up terms for like clearly defined technical research terms just because they're afraid that they're going to get fired because they are federal employees. They're receiving emails like this. I have also seen an email quite similar to this one, encouraging them to snitch on their colleagues. So people are not only required to report if they are currently engaged in DEI, diversity, equity, and inclusion activities. They're supposed to, if they are aware of a colleague, they're supposed to report on the colleague if they know that the colleague is doing any of these kinds of activities, and then they are even the sort of directive says that if it is found that you were aware of this and you did not report it, you could be at risk of losing your job. So the new NIH funding guidelines attack both freedom of speech, diversity, and accessibility protections for people with disabilities. This directive came out on the 21st, on Monday, a holiday. Again, reminder, right, disabilities impact 1 in 4 Americans. And so anybody who applies to an NIH grant now has to certify that they do not and will not, during the period of their award, operate any programs that advance or promote diversity, equity, inclusion, or accessibility for people with disabilities. So we cannot do anything to try and prevent the harmful health impacts of something that impacts together probably almost 1/2 of the US population. And furthermore, you cannot engage in boycotts of the state of Israel only. So I just want to take a step back because the sort of theoretical basis for this is that people's feelings will be hurt if you try to improve the health of people of color. So that's really an unfortunate framing. So it assumes that people, who I identify as white, would have their feelings hurt if we make sure that people of color get to live as long as white people. And so this is, an older definition, but so the President Trump actually did put this in an executive order in 2020. But a lot of this language is very similar. This idea that, no individual should be made to feel discomfort, guilt, anguish, or any other form of psychological distress on account of their race or sex. But I wonder if they should feel or experience like worsened health impacts, or if we should do anything to try and help them not to experience those as physicians and researchers. Psychological safety, on the other hand, and this is a sort of important thing because we've been, to try and understand, like, what is the real harm that we are causing when we make people feel uncomfortable about, horrific and very serious health inequalities that are happening in our country. So psychological safety is actually a term which has been studied extensively, and the term was codified by a Harvard Business School professor, and it refers to a shared belief held by members of a team that the team is safe for interpersonal risk-taking. There's also extensive research that demonstrates that workplaces are more productive, more innovative when they are more diverse, but that the benefit of the diversity occurs when people are able to have difficult conversations, when people are able to disagree and recognize that even if I say something and make a mistake, that I'm not going to be punished for that mistake, but that we can kind of work through it together and understand, and that feeling discomfort or being able to feel discomfort is actually what makes a team productive. So this kind of flies in the face of science. Oh, sorry, am I running out of time?
Just final thoughts.
Okay, sure. So ultimately, I just want to show that there is extensive research that shows that there are benefits to that there are things we can do, and that we should study this because if we increase the number of Black physicians in the population of doctors, we have see better health outcomes. And a majority of Americans disapproves of this anti-government and anti-diversity agenda. And so, in closing, I just want to point out that if we truly support the idea of life, liberty, and pursuit of happiness for all, we have to fight for access to conditions for healthy and prosperous lives, including food, clean water, safe housing, quality education for all. And we need to be checking on whether everybody has access to those things. And the only way we can do it is by asking those questions in our research and in our work. Thank you.
Thank you so much. Next, we will have our speaker, Sam Halpert, who's a lawyer and an accessibility advocate.
Thank you. So my co-presenters have been discussing the importance of two interrelated policies about masking in healthcare from the perspective of public health. First, the pledge that they've put together calls on medical professionals to ask their institutions to use masks year-round to protect patients. And second, the pledge calls upon them to ask their institutions to oppose mask bans in all forms. So why pledge to use masks year-round to protect patients? My colleagues have presented a medical argument. I think it's also worth considering a socio-legal perspective. If you think it may ever be appropriate for your institution to require masks in its facility, please consider that we may be in a use it or lose it moment. Just a few years ago, nearly 4/5 of US states had orders broadly requiring people to wear masks in public. Only 11 states did not impose mask mandates at any point. Obviously, we are in a very different climate now, socially. I hope it's not a controversial idea here that if a novel, highly contagious disease with severe immediate impacts and uncertain long-term consequences started to spread through the US in 2025, our communities and our leaders would be unlikely to respond with as much care even as they did in 2020. I want to emphasize how aberrant this shift is. Oh, I lost a paragraph. Sorry, my notes are muddled. Since then, over half of US states, state legislatures have passed bills limiting the emergency powers that states relied on in 2020 and 2021 to impose these mask mandates. In 6 states specifically, mask mandates themselves were prohibited. And that's the shift where I want to emphasize how aberrant it is. The ongoing effort to limit the ability of governments to respond to public health emergencies runs against fundamental understandings about what government power is meant to be for. Cicero, writing in the late Roman Republic, articulated the legal maxim that the health of the people is the supreme law. Since ancient times, governments have made rules constraining public activity for the sake of public health, including rules that curb individual behavior, especially in emergency circumstances. Simply put, it is extraordinary to see state governments intentionally strip themselves and subordinate local entities of powers that governments throughout history have found to be critical and indispensable to their purpose. I wanted to start by mentioning the basis of government authority to impose mask mandates here, because these changes within state governments where legislators are willfully disarming themselves and their constituent communities of ancient and critical tools provides the social context within which private institutions such as healthcare providers operate. Governments are not the only entities that make rules which affect our daily lives. Private institutions, like hospitals, can create their own rules and impose them on people who interact with those institutions. And their agency to create these kinds of rules is typically broader than government power because it is also less potent. Where individuals are not free to escape from government rules, they can, in theory, avoid private rules they dislike simply by avoiding those private institutions. At present, private institutions such as hospitals are still generally able to impose their own policies within their facilities. But healthcare workers should realize that, as with local health boards, a social movement is building that may ultimately disarm them of this critical capacity. The movement that is divesting local governments of their public health related powers may be starting to turn its attention to private institutions' authorities. In Florida, for example, the state's Surgeon General just spoke in favor of a revised Patient's Bill of Rights that would ensure that providers may not discriminate based on a patient's vaccination status. In Massachusetts, a bill that would limit private institutions' ability to impose, quote, health-related interventions, unquote, a term that specifically includes mask requirements, appears, thankfully, to have died in committee. For now, this movement has not begun in earnest to turn its attention toward private rules and policies. But the hint that it may, and the general pace with which these changes have been occurring, should serve as a warning to healthcare providers. The time to make masking in health facilities a standard, expected, and socially acceptable practice is now. Even if you are convinced that mask rules are a tool that is medically necessary only in extreme circumstances, you should be aware that it may be critically important to adopt masking more broadly now in order to preserve the option of using it in dire circumstances later. Second, why are healthcare workers' voices needed to oppose mask bans in all forms? Across the country, state and local governments have introduced, and in some cases passed, rules that burden individuals' ability to mask in public in a variety of ways. I'm running short on time, so I'll make only 3 brief points about what is a very complicated issue here, hopefully to aim healthcare providers' attention on this topic in a useful direction. First, it's important to recognize that people arguably have a right to protect their health that is, as the Supreme Court requires, quote, deeply rooted in this nation's history and tradition. As one of the most famous English jurists phrased it, there exists a right to, quote, preserve a man's health from such practices as may prejudice or annoy it. This is the ancient right to bundle up against the cold. People need to mask in public. Sometimes, most people should be masking, as with the wildfire smoke spreading across New York City as we speak. Some people should be masking most of the time, as with immunocompromised people in an environment rife with contagious pathogens like ours. It's critical that medical professionals support the argument that masks are a necessary tool for people to protect their health, and that many people need masks in public spaces in order to safely participate in public life, to form this link between masking as a practice and people's right to protect their health in public consciousness. Second, it's important to recognize that even rules that include exemptions for medical masking likely do not do enough to protect the interests of medically vulnerable people. As healthcare professionals, you are also well situated to explain to the public that police officers cannot competently judge whether a person has a medical reason for masking, and that they should not be expected to do so. Third, I'll just note that in addition to bills that burden masking, states are starting to introduce bills that attempt to support individuals who mask in public. These pro-mask bills, like the mask ban bills, probably deserve an entire discussion on their own. But for now, I'll just note that in addition to opposing bad rules, healthcare advocates can and should keep an eye out for good rules that may be worth supporting. Thank you.
Thank you so much. Finally, our last speaker is Nurse Rita Valenti, a community health organizer and
Andrew?
member.
Sorry, Nia. Isn't Andrew talking first?
Oh, sorry. Yes. Our next speaker is Dr. Andrew Wang. Sorry, I skipped over you, Andrew.
No, that's all right. Thank you so much. And this is such an important conversation that we're having today. And thank you so much for my colleagues here today discussing the importance of masking. We're also going to have a slight conversation about vaccination. COVID vaccines are so important to our communities, to our neighbors, to our friends and colleagues, and access is incredibly valuable. Any form of limitations of access can truly make it difficult and create unnecessary obstacles for people to get access to COVID vaccines. At the recent Advisory Committee on Immunization Practices, or ACIP, which was hosted by the CDC last week, a lot of the conversations that my colleagues were having in medicine, they were talking about a risk-based strategy. That risk-based strategy makes sense if you're trying to get into the fine details, but it doesn't work if you're thinking about access. These type of specific details only works at the clinical level, but when we're talking about access for the general population, or for people in general, you're limiting access if you think about a risk-based strategy, especially when COVID affects everyone. It affects people of all ages, it affects people at different life stages. The severity of infection can range widely for people of young age, middle age, older ages, and such. And we also understand that long COVID can occur among anyone of all ages, and vaccines can have some beneficial effects as well. So I think it's really important that my colleagues here, and we're speaking really to my clinical colleagues here, thinking about policies of vaccine access, and then also the public here, we need to be pushing for no limitations, no risk-based approaches. We should be ensuring that there is universal access to COVID vaccines, because if we create any risk-based approach, it ultimately creates barriers that limits people's abilities to access vaccines. It causes complexities, confusion, especially since COVID vaccines are accessed at pharmacies most times. And that type of risk stratification or determination can be truly confusing for anybody. And ultimately, when confusion leads to barriers and leads to a lack of access. So we're really calling for our colleagues to support universal access to COVID vaccines, because ultimately COVID infections are not ending. The pandemic continues to be happening. COVID vaccines are one of the main aspects of the approaches to protect people from severe infections, hospitalization, and death. And ultimately, masking, as we're speaking today, truly is the definite key component to protecting people in healthcare settings and outside. So thank you so much for having me. I look forward to the Q&A.
Thank you so much, Dr. Wang. And now we'll have our last speaker, Nurse Rita Valenti, community health organizer and member of Project South.
Hello, everybody. It's an honor to be here today. I wanted to just reflect very briefly on what these wonderful presenters have already said. And it brings to mind the fact that if public health is not about equity, it's not about anything. And we didn't just arrive here with the last election. We've had years of really eugenic policies based on a neoliberal approach to the undermining of all public health. Because public health is about, I take care of you, you take care of me, and we're in a society together. Now, as we're seeing this motion towards sort of attempts to consolidate really a fascism in this country, I think it's important that we know we have power and that our power can be used. And that's what I want to share with you today, the pledge to protect our patients. Hospitals should be sanctuaries. All patients come to healthcare institutions to heal, and hospitals must be safe for everyone. I pledge to keep my patients' immigration information confidential and to work with my coworkers to call upon all of our healthcare institutions to provide sanctuary to immigrants and others targeted by governmental entities. If we don't do it from the bottom, the administration at the top won't move. Vaccine access for all. Vaccine access is also under attack, from R&D funding cuts to uninterrupted disinformation campaigns. I pledge to stay vaccinated with the most up-to-date vaccines and to encourage my patients to do the same. I pledge to listen to my patients' reasons why they may have vaccine hesitancy and to do my very best to dispel that information. Masks save lives. As Dr. Ted Pack brilliantly discussed in his JAMA study, demonstrated that mask requirements and COVID testing upon admission mitigated airborne hospital onset viral infections by as much as 33%. The researchers note that, quote, nosocomial respiratory viral infections are associated with increased lengths of stay and high mortality in hospitalized patients, unquote. Meanwhile, mask bans are being pushed by the extreme right and some Democratic politicians as well, seeking to restrict people's rights to wear masks on campuses, in hospitals, on transit, in public spaces, infringing on bodily autonomy, religious freedom, and people's very health, and effectively barring huge sections, as Lara mentioned, nearly 50% potentially of our population from public life. I pledge to wear a well-fitting mask at work, to keep my patients and coworkers, my family, and myself safer. I will call on my healthcare institution. I will call on my healthcare institution to use masks and COVID admission testing year-round and to protect our patients. I will call on my healthcare institution and politicians to oppose mask bans in all forms. And finally, and critically, and underlying so much of this is fund care, not billionaires. No one should be turned away from healthcare and public services for lack of insurance or lack of funds. I will share this pledge with my coworkers. I will call on elected officials and join community actions to save and to expand vital public health entities, including NIH and other research funding, Medicare, Medicaid expansion, Social Security, and telecare health access, just to name a few. So know that as we're describing the conditions that we're currently experiencing, we can do something. We can do something right where we are at work and build from the bottom up. That's how change happens. Thank you so much. Thank you.
Thank you so much, Nurse Valenti. And we've dropped the pledge in the chat for anyone who is present who's a healthcare worker who wants to sign or check it out or send to other healthcare workers that you know. All right. In this time, we're going to address our Q&A. My colleague Cooper is going to read out some questions from the chat. Please feel free to drop any other questions that you have in the chat, and you can also direct your questions to any panelist that you wish.
I'll start with this question. I'm curious how the panelists would respond to the idea that healthcare practitioners have been traumatized since 2020 and masking policies prolong that trauma. It has been a rationale given from medical and public health leadership. How can that narrative be challenged? Alternatively, how can we call in clinicians to understand the importance of masking?
Andrew or Noha, do you want to take this one?
I'm happy to start a little bit here. You know, my clinic, we have a lot of people who certainly have been traumatized with the challenges that we faced during this ongoing pandemic, especially the early years of the start of the pandemic. And, you know, I think we as clinicians or healthcare providers every day face significant challenges in taking care of patients. And as we think through that trauma, you know, I think having a mutual respect for each other, but also being mindful towards each other of the importance of preventing infections, any type of infections to our patients. You know, we want to protect our patients. That's what we want to do. We want to ultimately protect our patients. And so, you know, I think keeping that as a reminder really, I think, helps with the healing process that we're still going through so much trauma, but also we want to heal through that. So I'd love to get other thoughts here.
Yeah, I like that response. And I could just briefly say, I mean, to the extent that we're dealing with unresolved trauma from the crisis, we need to address it. And I think we can do that as teams and as groups. And, you know, this is not the first time that healthcare has experienced trauma, but this was a massive global shared trauma that we seem to, as a nation at least, be attempting to sweep under the rug and just move on as if nothing happened. And I think that is the biggest mistake. And I think that what we're seeing now in terms of just rejecting science and really going against what the data is telling us is an emotional trauma response in a lot of ways. And so I do feel like it's important for us to address that piece head on as we continue to do what we are here to do, which is to protect our patients.
Thank you. We have another person asking, how should a patient approach a healthcare provider who refuses to mask?
This is such a difficult question. I think that, it's easy for me to say, vote with your feet, find another provider, but I also recognize that not everyone can do that. But I do think that there is a place for continuing to look to find a provider that is aligned with your values and beliefs and with science. And it does beg the question, if you're not willing to follow a precaution for me and for my health, then what else are you going to be sacrificing? And so I think having those honest conversations, again, I know that as a healthcare provider myself, it's easier for me to say that, because I think it can be very intimidating. There's already such a power dynamic within that relationship. So I think being prepared, having someone with you perhaps that can back you up and support you. And I think things like, the presentation today, the data that's been presented today, I have sent my patients to their specialty appointments with articles that describe the things, in the terms that maybe a provider will listen to and respect, which is, it's unfortunate. But there is a body of evidence, and I think coming armed with that and being as prepared as possible is the best way to go. And to the extent that you can exercise your choice, then I think that's a good thing to do as well.
I'll just try and take, because there were a few questions about the accessibility piece. One, I mean, and there is not a guarantee that you will win this, but I do recommend, and this is something that, a number of folks had been working on in 2022, writing a formal request for kind of an accessibility, an accommodation, that your provider be masked, that you be allowed to recover in a room, either alone or where everyone else is masked, etc. But that sort of specifying all of the things that would help to decrease your risk of infection. It also can help to try and schedule non-urgent procedures at times of year when the COVID and other respiratory viral rates are lower, though of course it's not a guarantee. It does help. I'll say I think it has been increasingly difficult to get especially larger institutions to agree to this kind of thing. Smaller ones are probably easier. There were some templates that I know that the Massachusetts Coalition for Health Equity, which I'm a co-founder of, had developed in 2022. I was trying to see if I could find one before the end of the webinar, but that would be something I can try and share if I can find it really quickly.
Dan?
Thank you. So we've had several questions come up about the ADA. Sam?
Okay. Can you, I was going to answer something else. Can you point me at the ADA related questions?
There are several. There's one about pseudo legal rights obligations that people have thrown out. There's a few in the chat.
Gotcha.
ADA accommodation request.
And also about proactive measures that people could take. I suppose you could speak to the what kind of language might be protective in legislation and pursuing that kind of protective language. That would be
right. So what kind of language that could be protective in legislation as far as proactive measures that people could take, I think is an evolving question. People are trying things and we're going to have to see what happens. Looking at the existing pro-masking bills that people have proposed and examining how effective I think they're likely going to be at their stated purposes is an entire webinar in and of itself, honestly. But to the extent that sort of what can people say on an individual basis in an individual context, I'm not competent, unfortunately, to give that kind of advice here. I would be really happy to sort of talk about pro-masking bills and what can be done. The biggest single piece of advice, the ones that I've seen that are sort of counter to the mask bans, I've seen some bills that have been proposed that would prevent local governments from passing rules that prohibit the use of masks for medical purposes. Like, the people have in mind, the bill that Nassau County in New York passed last summer, which is now the subject of a lawsuit. Very, very, very few of these anti-mask laws outright say that what they are doing is prohibiting masking, especially in a medical context, right? Some of them expressly say that they're not prohibiting it in a medical context. And if you ask the people that are supporting these bills whether their bill is a mask ban, they will almost universally say no. The issue is not that there are laws that are straightforwardly prohibiting masking. The issue is that there are laws that are imposing significant burdens on masks, heightening the risks for people who wear masks in public spaces in a way that's going to discourage the practice. And that's more nuanced. And I haven't seen the pro-mask laws tackle that nuance in a way that could potentially be helpful. I don't want to say more than that in this situation. So when people are talking about the ADA, do we mean people that are trying to leverage the ADA as a right that they have not to mask? Is that what we're getting at here? I'm sorry, it's hard for me to parse what's going on in chat. If somebody could frame the ADA question for me, I'll do my best, but I may not be able to answer.
I think one of the questions is what recourse do people have when they're going to physicians with these ADA requests if for some reason it's not honored?
Gotcha. Okay.
And you also mentioned that this is not legal advice and that people should not take it as
yeah.
Thank you.
Well, and it's gonna be easy to say the ADA is a very complicated law, and I'm not prepared today to walk people through what their options might be, what kind of recourse they might have under those circumstances. I think we could easily send. I think we've done programming related to this question in the past, and we could probably refer people to that in a resource after the fact. But I'm not gonna tackle that at the moment. I do want to tackle a couple of things. Somebody asked, how can it ever be legitimate for someone to legislate something that I'm wearing on my body? And somebody else said, how do we counter the pseudo-legal rights objections that people have thrown out, the argument that they have the right to choose, dignity at risk, etc. Those are interrelated questions. When is it ever appropriate to legislate something that I'm going to choose to wear on my body? Here, for example, I give you the Dyson snot cannon. For those of you that aren't familiar, this is an ill-advised attempt by Dyson, makers of the hand washing, the hands-free washing and the vacuum cleaners. They tried to create a non-invasive air filtration tool that wouldn't touch people's face. They thought that would make it more palatable. But what it does is it directs a pressurized stream of filtered air at you, which then means that air from you is being pushed at speed into the space around you. So perhaps it helps you as an individual, but it turns you into whatever you have is directed at everyone around you at velocity. I would like to legislate that. That seems like something where I would pass a law, frankly, that would curtail your ability to put that on your body. The issue, there's not, the government generally, not the federal government. The federal government is a government of limited powers, and they have to have a specifically prescribed justification for anything they choose to do, believe it or not. State governments have broad powers. That's why we saw these mask mandates come out from state governments. They have broad powers that are called police powers to do pretty much anything they want, as long as there is what's called a rational basis for doing it. If they have a rational basis for passing a rule, they get to pass it most of the time. The rational basis that they're going to give for something like a mask ban is public safety. they're going to say that people that are wearing masks are wearing them either for the purpose of intimidating the folks around them or so that they can avoid being identified while they commit a crime. And our desire to protect people from intimidation, or our desire to successfully identify and prosecute criminals, gives us a sufficient state interest to pass this rule. You move out of the realm of rational basis if you can show that there is an individual liberty that the rule affects. And once the rule affects an individual liberty, things get extremely complicated, but basically the government has to do more work to convince a court that the rule is not just rational, but important, and that they have made attempts to avoid stepping on the rights that are being implicated. So you don't have a general purpose right to wear anything you want on your body. You have specific rights related to free exercise of religion, for example, that you can wear something on your body that is part of your practice of your faith. That's a specific right. And it doesn't mean that the government can't pass a law. It just means that if the government does, they're held to a much higher burden to show that that law is strictly necessary and that they've made a real effort to limit its impact on your religious exercise. The same would go for something like this right to protect your health. And that's why I was saying that healthcare providers have a role here to sort of demonstrate that there's a real link between wearing a mask and somebody's ability to protect their health in public spaces. That real link is what gives them a right to protect their health. And it's that right to protect their health that imposes a higher burden on the government, a higher procedural burden before they can pass a law, not a general purpose interest in wearing the mask. We can also talk about a right to anonymity. There are lots of different ones in play here, but from the perspective of public health, it's this right to protect one's health that's important. And this relates to this question of how you get at the pseudo-legal rights objections that people throw out, the right to choose, the dignity of risk. There's not an ancient liberty for dignity of risk, right? There's not an ancient liberty to choose whether to infect yourself with measles.
All right, now we have to move on to.
Oh, sorry. Yes,
our
but
final
that's you
question.
have to be really specific about what individual liberty you are centering your claim in, and that is what helps you distinguish between these different arguments. I hope that that's a helpful high-level answer.
I think Cooper was going to take one more question, and then we were going to wind down. I believe there was a question for Dr. Pack.
Yes, let me see if I can find it. Okay. My understanding is that surgical masks are almost perfect at preventing spread if the person wearing it has a respiratory virus, but I am not sure I'm right about that.
Oh,
They aren't good at protecting the wearer, but are good at protecting those around the wearer. Is that right? Is that the question?
Yeah, I'm happy to just, I guess, talk about that more broadly. Obviously, masks exist on a spectrum of how well they prevent transmission of different kinds of respiratory viruses. I think a lot of the changes throughout the pandemic include broader awareness that there isn't this distinction, this binary distinction between droplet and airborne. It's more of a spectrum of particles that spread these viruses. Surgical masks are a little bit better at filtering out the bigger particles, while obviously there are gaps around the top and bottom. So for both the wearer, in terms of who might have the illness and who might receive the illness, on both ends, there is greater ability to transmit around the mask. That's why wearing an N95 is superior in almost all circumstances in terms of preventing both transmitting and receiving a respiratory viral infection. I think the data are a little bit more mixed about the exact percentages in terms of one mask on the transmitter and one mask on the receiver. There's not a whole lot of great data on the different combinations of that. The best kind of study would be a challenge study, but those are pretty uncommon.
Thank you. And so we're not going to answer any more questions right now. So if you have any more questions, you can reach us via our email address, which is info@peoplecdc.com, I believe. And yeah, thank you.
Thank you so much. Yes, that email is info@peoplecdc.org. And thank you everyone for attending today's panel. Please remember to sign the pledge, which you can link to on our website, and continue to follow us for more updates and more webinars like this. Thank you so much. Have a great day, everyone.